Hi there, my name is Mike Sullivan. I'm the Program Director of Valor Medical Services. I'd like to welcome you to this presentation from our series of continuing education for pre-hospital providers. Now, before we begin, there's a few things we need to go over. First off, the information presented in this program is intended for use by trained EMS providers. Also, due to variations in protocols and scope of practice among different states, departments, and agencies, this program may discuss or depict procedures, medications that are not acceptable in your daily use. If you see something in this presentation that varies from your agency's policy, always follow your department's protocols. Also, none of our authors or presenters of this program have any conflicts of interest or financial relationships they need to disclose. We do have documentation of this on file available in our office upon request. While we do our best to make sure that all the content we present is the most current available, participants are reminded that medicine is indeed a dynamic science and thus changes rapidly. So things may have changed since we've written or compiled this program. Please always follow the most up-to-date information available. In closing, if you have any questions about this or any of our other programs, please email us at info@valormed.net. Thank you very much and welcome to the program. Alrighty, now that we've got all that legal stuff out of the way, before we get started, let's talk about coffee for a second. If you're looking for a great cup of coffee, you probably want to check out coffeebrandcoffee.com. They're an online retailer, American owned and operated. They have a wide variety of coffees, teas, hot cocos, all sorts of different flavors. They've got all sorts of organic teas. You can get coffee in bean form, ground form, K-cups, whatever your heart desires. I've had several of the different blends and several of the different flavors. Absolutely fantastic. And because they are an American-owned small business, they don't have a big warehouse, so they don't have a big supermarket sales business. They roast it, they bag it, they ship it to you. It'll pretty much be some of the freshest stuff you'll ever get. Definitely highly recommend them. And they've got a promo code out for us now. If you use promo code VALOR SDS, you get a 5% discount off any order. So you can save a little money, try some fresh coffee, see what you like. They've always got different flavors coming through on their website. Some are permanent, some are limited time only. And if you look right there in the picture, you can see they've even got, yes, double caffeinated. Definitely a winner around this office. Alrighty, now let's get to class. Hi there, my name is Mike Sullivan and I'm one of the instructors with Valor Medical Services. In this presentation, we'll be discussing post-resuscitation care or post-arrest care. Now, the National Registry has a few objectives we'll be going over. We'll be identifying signs and symptoms associated with return of spontaneous circulation, also known as ROSC. We'll effectively manage hemodynamic instability, whether it be from hypotension or other arrhythmias. We'll investigate possible causes of cardiac arrest, and using this information, we'll be making appropriate treatment choices based on the cause and potentially even destination choices, determining the appropriate destination to which we should transport the patient. In addition, we'll also discuss the process of induced hypothermia and how that applies to pre-hospital medicine, although we don't do it quite to the extent that they do it in hospital. Now, before we get too far into this, let's go back into some of the keys to achieving ROSC. I've been an ACLS instructor for about 20 plus years, and I've always tried to convince my students and give them the impression that there are two sides to working a cardiac arrest. One half of it is actually managing the arrest itself. These things focus as in high-quality CPR, good compressions, cycling out compressors, maintaining proper compression depth, maintaining full recoil, making sure that we're appropriately ventilating, not under or over bagging, avoiding excessive ventilation that can result in too much pressure in the thoracic cavity, appropriate medication administration, not only appropriate drugs, but at the right time and the correct dosage for the patient. These things are keys to actually managing the arrest itself. However, there's another side to it. While we're managing the arrest, we also need to review possible causes. We can go through things as far as the patient history. What type of medical problems do they have? Any previous incidents? For example, are they a dialysis patient who missed dialysis recently? Or could there be something where they've had a cardiac incident? Are they on cardiac medications? Have they had anything go on recently? Many times we'll do our sample survey, going through looking for medications or past medical history, events leading up to this. And this yields into a lot of the HPI, or the history of the present incident, or the presentation. While we're working the cardiac arrest, and yes, making sure that we're managing it and doing good resuscitation, we also need to know how this started. Were they just found in this position, or did they complain of anything? Were they complaining of lightheadedness or dizziness? Was there seizure activity? Did they collapse? Was there any sign of trauma? We need to work this at the same side as managing the arrest. Because yes, managing the arrest is key to actually having a good outcome and potentially getting return of circulation, but also keeping them back out of arrest is very important as well. And if we know what put them into arrest to begin with, many times we can actually figure out how to not only get them back, but keep them back. So, there's the keys to working the arrest. Now, at some point, the arrest ends and we achieve ROSC, or return of circulation. One of the first things we need to do is identify that we have achieved ROSC. In order to do that, we look for several things. Now, identifying ROSC represents a major change in transition in our cardiac arrest care, and our priorities need to change and reflect that. Some of the ways that we will identify an achievement of ROSC is a sudden increase in the end-tidal CO2 reading. When the heart begins beating on its own again, it will be more efficient than our compressions were. Thus, any excess CO2 left in peripheral circulation will be washed out. As it starts to wash out, the CO2 exiting our tube will greatly increase. Another thing to look for is the presence of a pulse that will correspond with an organized rhythm on the monitor. We can also look for patient beginning spontaneous respirations. So, whoever is bagging the patient or ventilating the patient, if they suddenly realize they're not getting good compliance. As a matter of fact, the patient now is beginning to take over and breathe on their own. This would definitely be identifying we should check rhythms, check pulses, and reassess the patient. Lastly, movement by the patient. If the patient does begin moving, awakening on their own, their eyelids begin opening, again, this would be a good indicator that we've achieved a return of circulation. Now, as we've achieved this, we need to transition. Some of the key concepts in our post-arrest environment will be ensuring that we maintain appropriate ventilation and oxygenation. Our goal for this, or our standard for this, is an O2 saturation of roughly 94% or above. We don't need to get 100% O2 sat. 94% or above is good in the post-arrest environment. We also need to look at maintaining hemodynamic stability. When we say hemodynamic stability, that will be defined as a systolic blood pressure of at least 90. We will continue identifying potential causes of the arrest. We may initiate targeted temperature management, or code chill, or code freeze. And lastly, we need to realize that this is part of an overall care to support coronary reperfusion, and based on what the nature of the arrest was, if we can determine the cause, this may determine where we need to take the patient to maintain the best possible outcome for the post-arrest environment. So, how do we maintain our oxygenation and ventilation? Well, as I said before, we're looking for 94 or above. So once the patient is maintaining a SAT of 94, additional oxygen is not necessarily helpful. In many cases, it's now been shown that we were over-oxygenating the patient. This was resulting in free radicals and potentially cellular damage to vulnerable tissues in the post-arrest environment. Additionally, as I mentioned before, over-bagging or over-ventilating. This can increase thoracic pressure, and this excessive pressure may reduce the preload, thus compromise cardiac output and cerebral perfusion. We have to be careful not to let too much pressure build up in the thoracic cavity. A key to this is not only maintaining a good ventilatory rate, but also making sure we allow plenty of time for the patient to exhale between breaths. This exhalation allows more room for air to go back in. Ideally, we should be targeting our ventilatory rate and volume to an end-tidal CO2 of somewhere between 35 to 45 millimeters of mercury. If you can monitor this continuously, this will give you an idea that not only are we ventilating adequately, but we're making sure to give enough time to get the end-tidal CO2 out. Now, when we talk about hemodynamic stability, let's first look at the blood pressure. We want to make sure, again, a blood pressure of at least 90 millimeters of mercury. In order to do this, we'll of course monitor vital signs, ensure that we have good vascular access. If our initial access during the arrest was questionable or not that good or unable to push large volumes of fluid, this would be an excellent time to think about possibly getting a second IV place. We can do this because now possibly veins will be more prominent than they were during the arrest, and so having a second line could pay major benefits. Now, if the blood pressure is significantly under 90 millimeters mercury systolic, we may need to consider a fluid bolus. Typically 1 to 2 liters of either saline or lactated ringers will assist in getting the blood pressure up. Now, if you're in a situation where you're dealing with an extended transport and you've got a situation that's refractory to that fluid bolus, you may need to consider vasopressors. While this won't happen most times on initial calls unless you have a very extended transport time, you may see this done on interfacility calls or transports from an outlying facility to a major heart center or STEMI center. Vasopressors can be commonly used would include norepinephrine, dopamine, dobutamine, or epinephrine. Now, depending on what your agency carries, you need to be familiar and proficient with the tools that are at your disposal. Most of the time, most EMS units will carry at least dopamine, if not some of the others. I've got the doses there that were recommended from Titnally's Emergency Medicine, and again, be familiar with what you have on your unit and how you'll mix it, and plan this out in advance. For example, if you're using dopamine and you know you're going to start at 2 to 5 mics per kg per minute, you can have a baseline calculation done for this to allow you to do it in the post-arrest environment more efficiently. Now, beyond this, we also need to worry about arrhythmia management, maintaining hemodynamic stability. Now, arrhythmias may tend to crop up in the post-arrest setting, and we should be ready to treat them as they arise. This may include either administering boluses or infusions of various medications. In many cases, we may be actually needing to hang a maintenance drip of a medication that we used during the arrest itself. Here again, there are 4 common choices depending on what you have on your unit, what your agency uses, the patient-specific, or what your med control doctor recommends. You'd be choosing that medication. One thing to note, we typically don't administer antiarrhythmics prophylactically. However, we need to be ready to use them and be ready for the patient to take this step. If we begin seeing especially ventricular ectopy in the post-arrest setting, we need to get ahead of it so as not to return back to an arrest. So now let's look at some of these antiarrhythmics. The first one we'll discuss is amiodarone. Now, amiodarone is a class 3 antidysrhythmic. It's useful for treating both atrial and ventricular tachycardias. It works by extending the cellular action potential, prolonging the absolute refractory period, thus potentially slowing the rhythm and eliminating reentries. For cardiac arrest, the dosing for pulseless VTAC or VFib is 300 milligrams IV or IO, and you can repeat at 150 milligrams IV or IO one time in about 5 to 10 minutes. In the post-arrest setting, it may be hung as a maintenance drip. Typically, you'll start off at 1 milligram per minute infusion over the first 6 hours. Now, amiodarone comes in ampules and is typically mixed in D5 and water to make the drip. When we look at lidocaine. Now, lidocaine is a class 1B antidysrhythmic. It works as an alternate to amiodarone for ventricular arrhythmias, and it works by decreasing the automaticity by slowing the rate of depolarization of the heart. It can also work to make heart tissue less irritable. Now, the arrest dosing for VFib or pulseless VTAC is 1 to 1.5 milligram per kilogram IV or IO, and it's repeated at 0.5 milligrams to 0.75 milligrams per kilogram IV or IO. Your maximum dosing is 3 milligrams per kilogram. In the post-arrest setting, lidocaine is worked at 1 to 4 milligram per minute dose. Typically, you'll start at 1 milligram and you can titrate up to 4. Lidocaine is typically infused, mixed with either D5 and water or normal saline, and in many cases, it'll be done on a simple clock method with a 4-to-1 drip. Another antiarrhythmic we see in the field is magnesium sulfate, or mag sulfate for short. Now, it's an electrolyte, also works as an anti-inflammatory. It's used primarily as an antiarrhythmic for a patient who's been in polymorphic VTAC or torsades de pointes. Now, it can be used in VFib or pulseless VTAC that's refractory to other options as a second-line option. Dosing for an arrest for VFib or pulseless VTAC is 1 to 2 grams IV or IO, administered over 5 to 20 minutes in a very slow push. In a post-arrest setting, typically it's 0.5 to 1 gram per hour IV infusion, and again, this will be typically mixed in D5 and water. The last antiarrhythmic we'll talk about is procainamide. Now, it's been around for some years, and some systems don't carry it anymore. However, it is considered an antidysrhythmic. It's also used in many cases for stable monomorphic VTAC as a first line. It can also be used for re-entry SVT that's unresponsive to vagal maneuvers or adenosine. Now, the arrest dosing for this is 20 milligrams per minute slow IV administration. I've also seen it used with 100 milligrams every 5 minutes via a very slow administration. This makes it a little bit easier to push and maintain dosing. In the post-arrest setting, we'll typically mix it at a 1 to 4 milligram per minute infusion, very similar to the way we would lidocaine. The infusion typically here again is mixed in D5 and water or normal saline. Now, any of these antiarrhythmics, it's not so much which ones you have and which ones you don't have. It's going through and pre-calculating doses, figuring out how you're going to do it if and when you need to. Because I can tell you from experience, the last thing you want to do is have your post-arrest patient start showing signs of ventricular ectopy, and all of a sudden you're now trying to figure out how to mix a dose or which dose to use. So again, figure out what you've got and how you'll calculate the drip and how you'll actually mix it if you have to. Now, onwards and upwards, let's talk about more identifying the causes of an arrest. Once you're in the post-arrest environment and things have settled a little bit, you may want to obtain and interpret a 12-lead EKG. You'll perform your standard stratification. Do you have a STEMI? Do you have possible ischemia showing up? Or is it a non-diagnostic or otherwise normal 12-lead? If you're dealing with evidence of a STEMI or possible new left bundle branch block, you may want to transport to a specialty center for further treatment. A lot of this will depend on how stable the patient is otherwise and the distance from your facility to where you're at on scene. Many times this will be guided based on jurisdictional preferences as well as pre-planning in advance as far as do we need to take this to a community hospital, or if we have evidence on the 12 lead, of a cardiac event causing the arrest, maybe we need to go straight to the STEMI center. Again, this is something we should be discussing and planning out in advance, not waiting until the moment that we're dealing with it. We'll also look at the patient's medical history for clues to underlying medical conditions. Maybe there's an overdose. Is there a medication involved that the patient could have accidentally overdosed on? We can look for electrolyte derangement. As I mentioned earlier, a dialysis patient who's missed dialysis, somebody who's on specific medications that could be causing hyper or hypokalemia. Previous incidents. What's the patient's medical history? What's gone on in the past? Have they ever had an episode like this before? We can also look again at the history of the incident. Was there an injury? Was there trauma? Was the patient telling someone about, I'm having pain in my chest, or other anginal equivalents? If the patient was previously complaining of signs and symptoms that would be consistent with an MI, then going to a STEMI center would make great sense. Now, as we move into targeted temperature management, this has been shown in multiple studies to improve outcomes in patients post-arrest or after return of circulation. The current recommendation includes implementing targeted temperature management for adults who do not follow commands after return of circulation, regardless of what the initial rhythm is. This is done by lowering core temperatures to slow cellular metabolism, thus potentially reducing cell damage and free radicals. In the pre-hospital environment, frequently we'll use intentional reduction of core body temperature by placing cold packs to the neck, groin, or under the armpits. Many times in pre-hospital environment, we won't go for a specific temperature target as much as we'll do our best to initiate this. Once they get to the hospital, they'll be able to manage core temperature and measure it much more effectively. However, getting it started is good in the pre-hospital environment. It's also worth noting as we discuss this that the vast majority of studies show it does improve outcomes if initiated within 12 or more hours to 24 hours after return of circulation. The reason I mention this is, while it is potentially a great benefit to the patient, it does not need to be started within the first 10 or 15 minutes after return of circulation. So, let's focus on maintaining hemodynamic stability, let's focus on maintaining good perfusion, let's focus on antiarrhythmics as needed, and getting the patient to the right destination. If we can initiate this in the field, it is beneficial. However, please don't try to do this at the expense of one of the other modalities. Lastly, let's look at the whole goal of establishing an entire system of care to ensure not only reperfusion, but that we keep our return of circulation. It's good to note that most of the post-return of circulation deaths occur within the first 24 hours. Therefore, getting to a facility is great, but getting to the most appropriate facility is better. Many times we need to consider alternate facilities such as a STEMI or a PCI center, a cardiac care center, or a therapeutic hypothermia center if your jurisdiction has one. Once again, as I stated earlier, this is largely going to be dependent on what resources are available in your service area, how far you are from a community hospital versus a comprehensive STEMI center, and again, what resources you have, whether it's a ground transport or an air transport. Many times you may want to use the air transport to go to a more distant center and make that decision at that time. In closing, getting a return of circulation is great, but it's really only part of the big picture. The care following our return of circulation can not only help maintain the perfusion, but also improve the patient's long-term neurological function. We want the patient to go home, back to their family, and do so as neurologically intact as possible. Ultimately, good post-arrest care can help patients not only survive, but survive to discharge with better neurological outcomes. As I've mentioned several times through this, many times having a plan for, okay, we know exactly how we're going to run the arrest, we have all the algorithms memorized, Take some time and plan when we shift into post-arrest. What are we going to need to do for that transition? What are some of the things we're going to do? What are our drug calculations? Because when it happens, we need to be able to anticipate and work as well as we can to maintain our circulation while delivering the patient to the best possible facility. Hey there, I'd like to thank you all for stopping by, checking out our video. If you want more information about our company or any of the stuff we do, you can check out our website. If you need EMS continuing education hours, we do have our online education platform posted up there. Also, we have our email address if you have any questions. You can find us on YouTube, Facebook, Twitter, and Rumble. We maintain channels on all of those. Also, please like, share this out to your friends, subscribe, help support the channel, and we'll keep putting more videos out there for you. Oh well, enough about that. I know what I'm up for. Time for a cup of coffee. Y'all have a great day. Be safe out there. Bye.